Good afternoon, everybody. I just waited for the list of participants to stop increasing. So welcome to the Parliamentary and Scientific Committee webinar discussion on, it's an Ask the Experts briefing on COVID-19. And as you will probably be able to see, this is a webinar, so we can't see you, but you can see us. And it's been organised in partnership with the Academy of Medical Sciences, the British Academy, the Royal Academy of Engineering and the Royal Society. And I'm very grateful to all those organisations for their support and helping to pull this event together. Can I also welcome my panel of expert speakers, each of whom is going to be invited to give a presentation of around 4 minutes. One after the other, and then we will go to questions, as is the way with these things. And we'd like you please to use the question and answer function and drop your questions into there. Once we've marshalled the questions and sorted out the order in which they are going to be called, I will invite you to ask your question in person. You'll be unmuted and be able to ask your question. This is obviously a very, very important topic at the moment. There are obviously discussions about where we go now. We have a roadmap out, hopefully out of restrictions, but along with that, there are still some hurdles that we need to cross. We need to be able to make safe spaces that are COVID secure, and what that actually means and what the limitations of that. There's obviously a big discussion going on at the moment about vaccine passports and the implications that they potentially have, the impact of long COVID, and of course the emergence of new COVID variants and what that means for our vaccination program. So to help us explore that, as I said, I have 4 excellent speakers. I'm just going to introduce them to you now, and then we'll invite each of them to speak. We have Dr. Shaun Fitzgerald, who is from the Royal Academy of Engineering and is visiting professor in sustainable buildings at the University of Cambridge and a member of the SAGE Environmental Working Group. Shaun, good evening. Thank you for joining us. We have Professor Melinda Mills, who's director from the Leverhulme Centre for Demographic Science, University of Oxford and Nuffield College, and author of COVID-19, the Vaccine Deployment. Welcome, Melinda. Thank you for joining us. Then we have Professor Charles Bangham, Professor of Immunology at the Faculty of Medicine and co-director of the Institute of Infections at Imperial College London. Charles, thank you for joining us. And finally, we have Professor Judith Breuer, Director of Infection and Immunity, Professor of Virology at UCL, who sits on the BSI Immunology Advisory Group. I think you'll all agree that is a pretty stellar cast who will be able to take us through some of the topics that I mentioned. So I think with that, we will begin, and I will invite Shaun Fitzgerald to give us sort of his opening thoughts on this. Shaun, 4 minutes. I will start to sort of wrap you up as you're getting close, if that's okay, to try and keep us all to time. So Shaun, over to you.
Stephen, thank you very much indeed. And yes, I fully expect to be wrapped up if I go for 4 minutes. I'm actually going to endeavour to speak for rather less than that to allow more time for questions. I've got 3 things that I wanted to share with you regarding, from my perspective, what we have learned. Frankly, just about, well, it was a year ago when we went into our sort of the first lockdown, and I still remember waking my children off from university as term finished, and the world has changed dramatically since then. Number 1, when I got the call to join the SAGE Environmental Modelling Group, I was struck, really struck, by the power of science on the collaboration front. So this was bringing together so many disciplines, and we've got 4 of the academies represented, well, the 4 academies represented here this evening, but the wide range of disciplines that have been brought to bear to try and get us through this mess has been absolutely amazing, obviously under the leadership of the Chief Medical Officer and the Chief Scientific Advisor. But the scientific and wider community collaborating, including on the social science aspect in terms of what does this really mean regarding behaviours, has been absolutely outstanding. That's lesson number one. Number two is, from an engineering point of view, is a much greater understanding about the potential mechanisms of transmission, which will lead to something else. But those mechanisms are, number one, direct transfer of droplets or aerosol in close contact. In other words, going from an infectious person directly onto the mucous membranes of a susceptible. Number two is actually the indirect route, where usually the heavier particles can be deposited on a surface, and then somebody else, the susceptible, in all likelihood, putting their hands on that surface and then touching their own mucous membranes. And then number three, and this took a while to be really recognized by the wider community, is the potential mechanism for longer range transport in the form of smaller aerosols through ventilation systems perhaps, but certainly just within a room. So that's number two. Number three is actually what you can do about it. So the mitigation measures. And we're now very familiar with the hands, face, space, but I'm a ventilation expert. So actually I like 4: hands, face, space, and something like replace. And what's important, therefore, is actually all of the different mechanisms that you can introduce to try and intersect each of those sort of transmission mechanisms that I mentioned before, and they are all associated with those 4: hands, face, space, replace. I'm going to let others today talk about other things we've learned, such as vaccines, track and trace, and variants, but those are the 3 things that we have learned. And I wanted to leave you with 3 things that we need to do. And one is actually the power of data and sharing thereof, through things like events, but even modeling data that we can then use based from experiments such as from exhalation, especially looking at things like the viral content associated with what is exhaled from humans. That is still something that's very much work in progress. Number 2 is actually, how do we design our buildings? And we've got sort of emerging from this lockdown in terms of how we're going to go and cope with that. But what is it that we need to do in the future regarding design of buildings or retrofit to provide environments that are rather safer, more resilient to deal with not just this virus, but the next one? And then number 3 is actually the challenges associated with interventions and standards being easily understood to enable a comparison with other measures. And that is still work very much in progress. And with that, Stephen, I was going to hand over the baton to somebody else.
Shaun, thank you very much indeed. A lot of content in a very short time there, so thank you for that. Fascinating. I mean, over the last 12 months, it's actually 52 weeks today that the Prime Minister instructed us not to go to the pub. And then by Friday, the pubs were shut, and by Monday, the following week, we were in full lockdown. But we must have learned an awful lot in that last year, particularly around the mechanisms of transfer. Are some now understood better than others in terms of the risk they present? I mean, is the indirect surface risk as great as perhaps people perceived it to be a year ago? And did we underestimate the ventilation system issue a year ago?
So, Stephen, there has been a shift. So certainly much greater awareness of the role of aerosol transport and therefore ventilation systems like that. As I mentioned, it took a while for this to be recognized as a potential transmission mechanism. Right at the beginning, it was just not part of the discourse. But Stephen, right now, if you ask me what the relative contribution of those 3 mechanisms, so droplets, surface, and aerosol, and how they stack up against each other, I'm afraid the data is not there. All right. So even 52 weeks after kickoff, we are still left thinking, and I was addressing something only earlier today for an article in the BMJ, figuring out what's the wide range, or what's the range of certainty that I've got regarding the different importance associated with those 3 mechanisms. And Stephen, we're still needing more research, which is not just based on looking at sort of events and looking sort of after the event of what actually is happening, but from an experimental point of view within chambers and things like this. That is still work that is still outstanding, Stephen.
Okay, thank you. That's very clear, and I'm sure that will stimulate some further questions on that and the other points you made. So thank you. Right, we will move on to our next speaker, who is Professor Melinda Mills. And Melinda, welcome. Thanks for joining us. Same rules, 4 minutes, and I will give you a heads up when you're getting close to that, if that's okay. So over to you.
Perfect. Thank you very much. So I'm going to talk today about vaccine passports, and I wrote this as part of the Royal Society committee I'm on, and actually Charles, who will speak in a moment, is also on it. And I wrote it together with Christopher Dye. And I'm also on SPI-B and the SAGE ethnicity subgroup and the vaccine science coordination group. So sort of bringing those things together. And I really agree with what Shaun was just saying, that a lot of these topics require a very interdisciplinary approach. And vaccine passports is clearly one of them. And so what we did in the recent report, and you can get it on the Royal Society website, is we wanted to look at the different criteria, because we know already that some countries were already starting to introduce them, in Israel, in Saudi Arabia, and some other countries. And we wanted to start to think about, okay, well, what would we need to have everything in place? So what we did is we brought together 12 criteria, and I'll just outline a few of them right now. So the report doesn't advocate for or against vaccine passports, but rather it sets out the criteria, and we determined that it's feasible, but not all of the pieces are in place yet. So I'll just walk through a few of them to give you an idea. And if there's room for discussion, we can talk about those if you're interested in delving into some of them in more detail later. So the first one is about infection and immunity. So if you were to introduce this vaccine certificate or passport, we would really have to understand of the different vaccines, how immunity wanes over time. And we're still trying to understand that. So there would have to be some sort of expiry date. And then you have the other issue that we'll talk about later on emerging variants. And we know that some of them may compromise existing vaccines. So the certificate might have to be revoked at some moment. So there's those kind of issues, that talks about the science of infection and immunity. But then there's a whole bunch of technical or technological questions about, how would you introduce it? Would it be digital only, which some countries have done? And if so, is it interoperable across different platforms or different devices? Many others, such as Israel, for example, you can log in if you don't have a device and you can print it out. But then, you have some forgery questions or other aspects like that. It has to be portable. It has to be affordable for the government, but also for individuals as well, too. So there's a lot of different technical aspects. Another one is it should be international. So if we're going to use it, for example, for international travel, we know that we have the yellow card already. There are some precedents, of course, and we're already using testing for international travel. So there's the yellow card, all of these different precedents that would make you think, okay, we should have a international system. And the WHO does have the smart vaccination certificate. And we know that Ursula von der Leyen said they're thinking about legislation as well across Europe. And then just sort of finally, some really important issues as well, too. So what will it be for? And we talk about, you really have to outline what the defined uses would be. So would it just be for international travel, or would it be broader, like some other countries are doing? Would it allow you to get into a gym or a restaurant to access basic services? Would it be related to having a job? And what's the responsibility of the employer, or duty of care for their staff or residents or customers? And then we get into ethical questions, but we also get into some tricky legal questions as well, and where the responsibility is. In terms of legal aspects, you have, for example, so if you were about to roll it out tomorrow, you'd have not everyone would have access to vaccines. So, you'd have to have that everyone would have some sort of availability and enough of the population would be vaccinated. You also have to think about who would be excluded. So we have higher vaccine hesitancy, but also lower uptake for convenience and multiple reasons in ethnic minority groups. Also, you have to think about what would you do with children, pregnant women, people with allergies, people with religious beliefs, or people that don't believe in vaccines. How would you exclude them? And you'd have to make those kind of choices. And I guess just finally is a really important one is the behavioral one. So, if we bring it, will they use it? Will people trust it? And there's been a lot of discussions. You're probably aware of the petition. People are worried who will have access to this data? Is it secure? Will commercial companies have access? Will it be linked to my housing? Will it be linked to immigration status? And there's lots of questions still. So that just gives you a flavor of some of the criteria, and I'll stop there.
Melinda, thank you very much indeed. I mean, I think you hit on a rich vein of challenges towards the end there. I mean, I think we can all understand how useful a vaccine passport might be, but the issue and what I see in my inbox is the potential for creating a two-tier citizenry of those who have and those who haven't had the vaccine. I mean, the group that you worked with at the Royal Society, I mean, how far down that path did you go, looking at whether it is fair to potentially exclude some people from normal activity within society because either they haven't had access to vaccine or they choose not to have it? You know, we're not a country that mandates vaccinations. Where do you think the next stage in the development of this idea should be?
Well, I think many countries are introducing them, and it's been discussed at the European Union already. So I think it's, you know, there has to be some sort of stance and position taken on it. I think, you know, vaccines aren't, even in Israel where they use it, vaccines aren't mandatory. So vaccine passports likely won't be mandatory. And it's not, and that's not something that works, we know, with the public as well too. Positive messaging is much more effective as well too. So not criminalizing or not, you know, forcing, making them feel bad or things like that, that's not as effective with the public. So, but I think, you know, as long as you're aware of who you exclude and you have some clear criteria, you know, and I think that the UK actually is a population where a lot of people will have uptake within the next few months. So, you know, you just have to understand if there are some exclusion restrictions, just like with face coverings, you know, people that couldn't wear them for various reasons, you just have to be very clear about it, but also define the uses. And otherwise, you know, we get emails from businesses saying, what will I need to do?
Okay, great, thank you. I'm sure there may be further points made along those lines, but thank you. That was very interesting summary of the challenges. Right, we'll now move on to our third speaker, which is Professor Charles Bangham. Charles, over to you. 4 minutes, as I said, same rules. I'll give you a heads up when you're around 4 minutes. Over to you.
Thank you. My normal stamping ground is virology and immunology, and I'll be very happy to come back to any questions that might arise on the general aspects later. But what I want to do is to focus at the moment on a very specific aspect, which I think has been underappreciated until quite recently, and that's the so-called long COVID syndrome. We now have a reasonable understanding of how the acute disease of COVID-19 is caused. We know some mechanisms that are slightly uncommon in other viral infections. And typically, of course, you know, it's a biphasic disease. So as indeed the Prime Minister experienced, after about 1 week of feeling very tired and having a fever, he began to feel better. And then abruptly, a couple of days later, he got a lot worse. This is very typical. But typically the people, even those who develop the severe disease, will recover after 3 or 4 weeks. But it's now becoming increasingly obvious that a proportion of people develop symptoms that are much longer standing. They, in fact, some have gone on for more than 9 months. And this is become known colloquially as long COVID. But there are a number of real problems. The problems are, first, that it's extraordinarily heterogeneous and very variable in its symptoms. People have fatigue or chest pain or breathlessness or the so-called brain fog, the confusion. The fatigue is by far the commonest single symptom, but there are really an alarming variety of very different systems that are involved. And one of the most perplexing things is that not only it varies between people, but within one person with the syndrome, long COVID, it can vary quite dramatically over time, even from day to day. And it doesn't necessarily start immediately after the acute disease. So because of these extraordinarily variable presentation of the condition, it was initially dismissed by many doctors and others as being psychosomatic or imaginary, but it's now absolutely clear it's a real condition. And the problem is we have much less indication than in the understanding of the acute disease. How is it caused? What's actually going on? And for that reason, it's extraordinarily difficult to treat. At the moment, the treatment is completely empirical. So just to give a flavor of it, it's now estimated by the WHO that something like 10% of people have symptoms that carry on for more than 3 months. But it depends, of course, how you define the symptoms, which symptoms you include in the syndrome. The NICE definition, the National Institute for Clinical Excellence, defines COVID as being for 3 weeks, ongoing COVID up to 12 weeks, and then the post-COVID syndrome, which most of us would call long COVID, if it goes on for more than 3 months. So, as I say, the problems are to know how to define it, how to identify it, and most of all, how to treat it. And because at the moment we're still only a year into the epidemic, we really don't know how long this is going to go on. Some people have been very disabled, and it's not at all clear how long it's going to go on, but it is clear that it's already imposing a very significant burden on the health services, and it's likely to continue. Thank you.
Giles, thank you very much indeed for that. Just for a point of clarity, and I'm sure this is the case, could you suffer with long COVID and not know that you've had COVID in the first place?
The answer is yes. Some people, it's slightly commoner in older people. It's slightly commoner if you have symptomatic COVID, but some people who have developed long COVID, so-called, have actually had very mild or even asymptomatic primary infection. It's less common, but it has been recorded.
And does long COVID present in a similar way to other fatigue-based conditions? And can it be treated, I suppose, therefore, in a similar way to some of those? I'm thinking particularly of ME.
Yes, the so-called post-viral fatigue has been recognized for a long time, and of course it's still hotly debated whether it is how much of an organic basis it has. But it's equally poorly understood, the long COVID. So as I emphasized, the treatment of both any post-viral fatigue syndrome and long COVID remains very empirical. People are just trying different things like steroids to test whether they might help. At the moment, it's entirely experimental.
Okay, thank you very much indeed for that. Very, very interesting. Right, we'll now move on to our fourth and final presenter. Please don't forget to use the Q&A to submit your questions, because after we've heard from Judith, I'll be throwing the questioning open. Judith, welcome. Thank you for joining us. And we very much look forward to hearing what you have to say. Judith, same rules, 4 minutes, and I'll wrap you up if you're massively overrunning.
So thank you very much for asking me to speak. This is really about the success of genomics in the UK, because we know so much and everybody seems to be an expert now on variants. And that has been because the UK has been one of the largest sequencers of the virus, I think contributing over 50% of the viral genome sequences in the databases. So what do we mean by a variant? Well, a variant is a collection of mutations in the genome. It's the letters in the genome and the changes in the genome that occur. And how do variants arise? Well, viruses naturally, when they reproduce, they introduce changes, they introduce mistakes into their genomes, and variants occur that way. But actually, SARS-CoV-2 is a pretty stable virus. It's much less variable than other RNA viruses. And actually, the biggest factor determining the rising of variants is transmission. And the more transmission you have, the more variants you will see. So transmission is key. And it's important to remember that there are thousands and thousands and thousands of variants. So every time the virus transmits, And every time the virus reproduces itself, it's liable to introduce new mutations. But we're of course not following all of them. So the key thing is, how do we decide what we need to look at? And for that reason, in order to deal with that question, the community, the viral genomics community has come up with a number of criteria that identify a variant that we think is of particular interest. And broadly speaking, a variant of interest is a genome with a constellation of mutations that has particular immunological, epidemiological, and pathogenesis of interests. And by that we mean, how does it interact with our immune system? Can people who've been infected before become infected with this? Is it more likely to cause death or severe disease? That's the pathogenesis. And the epidemiology, is it more likely to transmit and cause more infections and therefore a bigger burden? So how are we dealing with these variants? Well, the important thing is to continue with the genomic surveillance. That's what we're doing all the time. That has to continue in an unselected way, where we look for these variants and we can pick up not only the ones that exist, but also identify others according to our criteria. We have to keep programs which allow us to characterize these biologically. And then we have to understand what we can do to actually use the information to mitigate the impact of the pandemic. And basically, we are using this information to inform policy. If we know that variants are transmitting fast, and we know we have a new variant, then that allows people to make decisions about what to do with regard to trying to mitigate transmission very rapidly rather than waiting to see what happens. We can also inform the vaccine, the vaccine development, so that the impact of new variants and their biological characteristics will be fed into the vaccine program. And we're looking to the future as to how this massive explosion, this massive development in the UK of pathogen genomics can be pulled through to perhaps inform future pandemics and future epidemics.
Spot on, perfect timing. Thank you, Judith. Very interesting. You said there are various potential new variants out there, and you have to pick ones that you wish to follow. How quickly are you able to identify targets for following? And what was specifically interesting around the Brazilian variant that obviously meant that we pulled out all the stops to try and track down all the cases as quickly as possible? What did it present that you thought was was perceived as such a great risk to community?
So there are a number of criteria that we apply to actually identifying what we consider a variant of interest, which is something that has the properties, and that is around the appearance of a lot of new mutations very rapidly. A virus, as I said, is generally not fast mutating. So if we see a virus that suddenly has a lot of new mutations that have not previously been identified, that was what happened with the UK B117 Kent variant, particularly if they're in what we call the spike protein, which is the protein that binds to the receptor and is the target of most antibody and vaccine-induced antibody. Those sorts of mutations raise alarm bells. With the other factor is if we see that it's spreading, and the thing that raised particular problems or particular alarm bells with P1, the Brazilian variant, was that it seemed to be spreading in a population that had already been infected quite highly in the previous first wave of the epidemic. It became a variant of interest very quickly because of this anecdotal reporting, but we needed to have more information to firm that up, and that is gradually appearing now. So it had all the hallmarks, lots of mutations, some mutations we know already are biologically of interest, that they've appeared in other variants. That's the other criterion. And then also this reports, which are now being firmed up, of it spreading in a population that was already highly immune.
Thank you. That was very helpful and very clear. Right, we will move on now to questions. And I think the first question is from my colleague, Paul Beresford. Paul, someone will unmute you, and if you can then pose your question. You're on.
Thank you. Sorry, I finally found the button. What I'm really asking is, as possibly known, I've got two jobs. One is an MP, the main job, and occasionally I do some dentistry. What level of defeat of the virus and the vaccination will allow us, for the dental profession, to reduce the level of protective wear that they're now using when they're ever using aerosol equipment? Are we ever going to reach a safe stage?
Would anyone like to try and address that, bearing in mind, I think we've all accepted we need to live alongside COVID? Is the PPE that dentists have to wear now inevitable for the foreseeable future?
We are therefore introducing the requirement.
I don't know. Sure, looking sort of if you could form an answer or at least comment on that.
So I'll have a go. I think it's extremely difficult to be able to answer that question, and it's a critical question, of course. But there are certain aspects which are going to be, certainly the level of prevalence in society is going to be a very, very key factor as to therefore what measures. And I'm talking about beyond dentistry, the question you just posed, but about actually what relaxation of mitigation measures, physical mitigation measures that you might be seeking to introduce in order to allow society to function. And whilst clearly we're coming down the curve at the moment, but the whole purpose of society being able to function, there are lots of other areas of society which are obviously have been absolutely hammered as a result of not being able to have people there, or very, very limited numbers. The actual, the close proximity is something that I would expect is to do with a judgment call regarding the risks of infection and actually the level of annoyance or interference that a given mitigation measure might have. And if it's to do with PPE in particular settings, it's a very specific question, but at the end of the day, I think it's going to come up really regarding weighing the what are the added benefits in terms of risk reduction versus what are you actually preventing or encumbering society with as a result of mitigation measures in place. So I fear that's probably a long-winded answer, but I don't think it's an easy question to answer.
Thank you, Shaun. Judith, please.
I would entirely agree with that, but I also think that we must remember that we have other viruses and other infections that present a risk to dentists and others, and we continue to use PPE for those. So there may be a need to use some PPE for the foreseeable future. But if we get to a situation where the prevalence of this virus is extremely low, where we know that vaccines are completely or almost completely preventing disease, then and also where we have rapid testing available, on demand, so that people can test themselves before they go to the dentist, you may see, that may pave the way for a much more sort of normal interaction. But there may be a need, as we have for hepatitis B and HIV, for protective measures, for dentists to take protective measures for the foreseeable future.
Thank you. Right, next question is from Lord Norman Tebbit. Norman. Someone will unmute you. Here we are.
You're unmuted. Thank you. Yes, indeed. My question is fairly straightforward. Since the virus mutates so widely and so quickly, does that risk rendering the vaccine ineffective?
Who would like to comment on that? Charles, and then Shaun.
The evidence so far is that the variants of concern and the variants that we're worried about do partly escape the antibodies that are raised by the vaccine. But so far, most of the evidence is that the existing vaccines still prevent severe disease relatively efficiently. And so at the moment, it doesn't appear that it's a major risk. However, it's clear that the virus will continue to mutate. We will continue to develop new variants that spread more easily, as Judith Breuer is saying, and it will be necessary, almost certainly, to update the vaccines, perhaps every year. Just to amplify what Judy was saying about the variants, the genome of this virus has roughly 30,000 letters. The average difference between any two viruses, if you take the virus from any two people, they differ at 10 of those positions, which you might call 10 variant positions. So it really is important to realize that there are thousands and thousands of these variants. And indeed, it was the existence of these different variants that made it possible to know that last January and February, there was something like more than 1,200 different introductions of the virus into this country, mainly from Italy, Spain, and France. And of course, it was largely attributed to the people who'd been skiing there. But the reason we know that is because there were over 1,200 different sequences. So it's really possible to use this molecular information in an extremely important way. But the huge majority of these mutations simply don't make any difference, either to the severity of the disease or to the protection given by the vaccine.
They also knew about Cheltenham.
Thank you very much indeed, Charles. I don't know if anyone needs to comment. That's not, no, that's fine. So thank you for that. My next questioner is Baroness Neville Rolfe. Lucy, I think someone will now unmute you. And yes.
Yes. Yes.
Hi.
Hello. Thank you very much. There's a system of ionization. It's called Cleanse Air, which somebody has mentioned to me, that cleans the airspace and surfaces, killing the viruses. I think not only COVID, but anything. It's apparently used in the Kennedy Space Center by Google, etc. So it's an American process. And I was wondering what Shaun thought of that sort of thing, because clearly, if this is going to go on, you know, we need systems that will reduce infection in places like hospitals and shops and theatres.
Thank you ever so much indeed for this rather important question. It is extremely important that we get to grips with the broader offering that is being sort of provided by lots of areas, companies in society regarding air cleaning devices, surface cleaning devices. Let's talk about air cleaning devices. I mentioned in my opening remarks that there was one thing that I thought would be my third area that I thought needed to be addressed, which was to do with standards and a clearer articulation of how to interpret those sorts of offerings to society. And this is but one of those. So, for example, if you have a room with an infectious person in it, then no matter what the air flow rate is or the air cleaning devices that you have deployed within your space, you will never, ever, whilst that infectious person is present, have a situation where the room is therefore completely devoid of virus. Now, clearly, when an infectious person is not present, then there is a time scale over which, let's say, the concentration of virus can be halved, and the higher the ventilation rate, that's bringing outdoor air into the space, or the flux through an air cleaning device, you can reduce that time scale. But you will always be left with some virus within the space. It's just what we call exponential decay. And I have seen in the literature really quite a lot of sort of claims from various companies giving very high numbers about, this is a device that's 99.97% viruses can be addressed by this bit of equipment. And what it fails to therefore then articulate is that, well, but the effectiveness of that bit of equipment in a room is highly dependent on the flux of air that's being passed through it and the rate at which virus is being generated within the space. So it's rather complicated. I would personally like to see basically an easy benchmark to be able to evaluate one method versus another. And that other standard method for me is one where most people can get their heads around is, well, what's the sort of the ventilation rate, for example, opening a window and comparing an air cleaning device, is it like doubling the ventilation rate, tripling the ventilation rate, but it isn't getting it to be completely safe. So that's what we need as a society. And Paul Monks from Bayes is absolutely aware of this, that there's a need for development of standards by which these sorts of devices can be compared.
Thank you. Excellent. Right. My next questioner is Baroness Tyler, I believe. Claire? Excellent. Remember to unmute.
Yes, thank you. Picking up on the discussion about the vaccine passport, I just wanted to know what panel's views were about health and social care home staff being required to have a vaccine if they are in close contact with patients or residents as part of their professional responsibility, as I think Chris Whitty has termed it, and whether you feel the duty of care towards vulnerable patients should trump individual choice, and that staff who choose not to take up the vaccine, other than on medical exemption grounds, should either be redeployed or have to find work elsewhere.
Thank you for that. A very good question. Melinda, I don't know if...
Sure, yeah, I can take that one. It's a difficult one, and I think I would land on the side of Chris Whitty on this one, because it comes down to, you know, the duty of care for employees. So then other employees around you, but also the staff as well. But then you'll get into sort of slippery ground where there'll probably be some legal cases, and we've seen them coming up already, where people come forward, they've got allergies, they've got medical exemptions. So those all seem, you know, quite clear. But then people will come with religious beliefs or political beliefs or other reasons why they're not going to be vaccinated. So those things have to be discussed, and, you know, they'll have to make some clear criteria. And I guess it will also come down to beyond care homes. There's already discussion for staff that have had high infection rates in bars, in gyms, all of these different things. So it's a legal question, but it's an ethical question. And what some countries have done is, you know, not made it mandatory, but then the businesses are sort of negotiating it and dealing with it. So in Israel, you know, after they introduced it, that's the first question that came up from businesses. So the Attorney General then ruled that, no, we can't do this. But then the Ministry of Health came in and said, well, it's a duty of care. So actually we can look at some of the precedents. Obviously we've got a different legal system, but there's already some discussion in other countries as well.
Thank you for that. Very interesting. I'm now going to go to Carol Moynihan, my colleague, and then to Stephen Benn.
Thanks very much, Stephen. Thanks, and thanks for all the contributions so far. It's been really interesting. I've actually got 3 questions, but I'll try and keep them really brief, Stephen. First of all, following on from the topic of filtration systems and air conditioning or air purification, airlines are currently trying hard to persuade us that it is safe to get back onto an aeroplane because their filtration systems are far better than any other used. So I would like some comments on that. We're talking about mutations earlier. I mean, last summer we were looking at sort of elimination of the virus. We got the numbers extremely low. Now we seem to be talking more about a situation of an acceptable level of deaths. And I wonder if we accept that we are living with the virus for a longer term, are we encouraging mutations to take place? And the last thing really is probably directed towards Charles is I'm the chair of the APPG, the All-Party Parliamentary Group on ME, and we've looked a lot about the treatment or better management of ME and post-viral conditions. And I just wonder why there is not more consideration been taken of how conditions like ME are managed whenever we're looking at the management of long COVID. Thank you very much, Stephen, for indulging me.
Thanks, Carol. Who would like to start on some of that? Shaun.
I'll just take question one, Stephen. Airlines. I have looked at modern aircraft, and there's something called the air change rate, which looks at basically the volume flux of air through a space and how many times an hour is the volume flow rate coming in, equivalent to a certain air change rate. It's not exactly the same because it mixes. Aeroplanes are small spaces and they have a very high ventilation rate relative to the volume. You get something like 20 air changes an hour, which is equivalent to, think of it as an air displacement of every 3 minutes. Now, the reality is it isn't actually being displaced every 3 minutes because you get mixing within the cabin, but it is a very, very high flow rate. So, and I've never seen any other environment, for the public at least, with those sorts of ventilation flow rates. So in that particular instance for aerosol transmission, if you're at the front of the aircraft, the back of the aircraft, and you've got an infectious person at the front, I would expect that an hour on that aircraft is rather different than being an hour somewhere else in a building. Nevertheless, that's only aerosol transmission. It doesn't overcome the issues to do with surface transport and droplets. And then if you're in very close proximity to that person, you're going to be within their cloud of virus particles anyway. So whilst they're safer, Carol, I'm not going to suggest that they are safe without these other issues being considered.
Thank
you. Carol's second point? Yes, Judith?
So I think it's going to be impossible to eliminate SARS-CoV-2. Even if we were able to eliminate it in the UK, it would be spreading in other parts of the world where it's not, which maybe have less good health infrastructure. And I think we couldn't actually eliminate it in the UK. But I think that we can learn to live with it. And the idea is to try and minimize transmission as much as possible. But actually, we can learn to live with it. I mean, we live with influenza, which appears with a new epidemic strain every year. And we have a very effective vaccination program that accommodates to that with a change of vaccine every year. And the other thing to say is that we know that seasonal coronaviruses infect us every winter, and that immunity to those is not very long-lived. And it's quite possible that SARS-CoV-2 will eventually mutate to become less virulent. And so, in fact, it's not necessarily the case that accumulation of new mutations will lead to more virulence. It actually may have the opposite effect. It may lead to us accommodating SARS-CoV-2 as we do the ordinary seasonal coronaviruses.
Thank you, Judith. And then I think the final point was to Charles. Yes, Charles.
Just to say, I completely agree with what Judith Breuer has just said. And again, to re-emphasize a point you mentioned earlier, the rate at which the virus mutates depends on how much replication it undergoes. That is, how many people get infected and how many virus particles are produced, because it has to undergo that multiplication in order to mutate. So when the prevalence level of the infection goes down very low, there are very few people getting infected. Excuse me. And also, if they're vaccinated, it will not reproduce so effectively. So the mutation rate, the net mutation rate, will go down a lot. So it becomes much less of a risk. On the question of the treatment of long COVID, I think people are now beginning to draw more parallels, as I mentioned, between other types of post-viral fatigue syndrome and long COVID. But it's important to emphasize, we don't understand either condition, and the treatment of both conditions does remain, as I said earlier, empirical. In other words, symptomatic. We just have to try and relieve people's symptoms, but without a proper understanding of what's going on inside them. So it's been extremely frustrating. It's been notoriously difficult for so-called ME or post-viral fatigue. I personally nurture some hope that because it's now so clear that such a similar syndrome is caused by a very well characterized agent, that we might have some possibility to understand how long COVID is caused. And if and when we do, it might illuminate what we can do better about other forms of post-viral fatigue like ME. And I should say that the NIH in the States has just invested more than $1 billion to work on research and treatment in long COVID. And similarly in this country, the National Institute for Health Research and UKRI are investing major sums in this condition because, as I said, it's becoming increasingly clear that it is imposing a large health burden.
Charles, thank you. Right, I'm going to go to Dr. Stephen Benn, and then I'm going to go to Lord Boyce. Stephen.
Thank you very much, Stephen. Shaun, at the very beginning of your own address, you referred to the importance of scientific collaboration. And Melinda, when she spoke about the work done on vaccine passports in the study of the Royal Society, similarly, collaboration is key. Can I ask how much international scientific collaboration there is going on the issue of vaccine passports and the issues involved with them? In other words, are scientists talking internationally in other countries to each other? Because, of course, any system for international travel, for example, is only really going to be effective if it's common everywhere. What type of discussions are going on?
So, Stephen, I can talk about collaboration internationally more generally, but Melinda, are you better placed to talk about the passports issue?
Sure, I can address the passports, and then Shaun, please go ahead. So yeah, about passports, I mean, that's one of our criteria, that it has to be internationally standardized. So we know the WHO has this smart vaccination certificate that they're thinking about. But what you see is a lot of countries are introducing their own passports. And I think I saw a couple of questions also in the Q&A that talk about this. Well, what if someone flies in from Japan? Or, how will that work if they're not vaccinated? All of these kind of challenges, come to the fore. So how would we deal with it? So there is international discussion. The WHO hopefully will soon come out with some sort of mandates and criteria, and I think many of them are overlapping with the 12 criteria we talk about. But they really, we can already see. I saw someone else asked about the IATA ones that were introduced by Qatar Airways today as well too. So that's in line with the WHO. So the World Health Organization is already doing these pilots. They did it in Estonia, and Estonia's rolled it out. They did those in December. So that's definitely happening. But where you'll have the friction is there's different legal systems in the different countries. And that's where, that we're getting these battles. But the ethical questions remain the same. Whether it's going to be digital or how forgeable is it, those are all kind of major questions. But throughout this, we've learned that international collaboration and learning from other countries is just so key in terms of policies they've introduced and what's been effective and not. But I turn it over to Shaun.
So my answer will be very short, Stephen. Science knows no barriers, borders. So the degree of international collaboration on the scientific disciplines of research is extensive. And it's not just at the governmental level, it's actually people like the Royal Society convening panels, conferences, where actually you've got international scientists. They're all publishing papers and actually talking to each other, learning from each other. And early on in the epidemic, especially, Stephen, when we sort of had the case studies coming from Asia ahead of us, for example, were clamoring for data and understanding to actually unpick that, to learn from each other. So I would say that I think it's the spirit within the scientific community and engineering community at large has been extremely positive in terms of helping us navigate.
Thank you.
Thank you, Shaun, and thank you, Stephen. Our next questioner is Lord Boyce. Michael.
Thank you very much. My question is slightly off-piste from the four very good presentations we've heard. It's about the flap going on regarding AstraZeneca. and the two sort of cries for help regarding either blood clots or also some bad side effects. What seems odd to me is that the countries who are complaining about this or doing something about it have had a tenth of the number of vaccinations we've had. We don't hear any reports in this country about blood clots or side effects, but why are we hearing it in other countries? And I have got one personal experience of this, and that is that my daughter happens to live in Spain, she's a teacher, and they all had their vaccinations last Wednesday, and half the teachers went down with side effects. They couldn't go to work the following day. So I wonder if you say something about these side effects that are causing a real slow up in the whole vaccination process in Europe anyway. Thank you.
Thank you, Charles.
Thank you. Yes, it was inevitable this question came up. It's of course extraordinarily important. And like any other adverse event in medicine, there's a very well recognized system, the yellow card system, for reporting this and to make sure that the cases get properly investigated. I want to make 2 points. The first is just to put it in context. I looked up earlier today that in the total of something like 17 million people have now been vaccinated with the AstraZeneca vaccine, and the total number of reported cases of thromboembolism is of the order of 35 or 40, maybe 40 now. That's in the UK and in Europe combined. To put that in context, between 2008 and 2017, there were more than 7,500 people admitted to hospital with venous thromboembolism every year in Scotland alone. And Scotland has a population of 5 million people. The point is this: it's a very common condition, and there are many, many well-known predisposing factors. So it doesn't prove that the vaccine does not cause it, but just to put it in context, the number is actually, the number that have been reported is very much less than you'd expect on the average from that size of population. So that's in Scotland, more than 20 people a day on average over 10 years admitted to hospital with the condition. So it puts it in context. The other point is a more theoretical one, and that is that it's not at all obvious from what we know about the vaccine, how it's made, and the immune response and the other effects that it elicits. It's not at all obvious how this would happen, how this would specifically predispose to blood clots. But it remains very important to investigate it systematically.
Thank you. And the issue of relatively mild, although side effects following the jab, the fact that teachers all had the jab and half of them went off sick. I mean, I think that is a fairly well established side effect, isn't it? I mean, people have that with the annual flu jab to an extent. It's just we're doing this at such scale that it's bound to be observed more frequently.
I've had it myself. I felt quite under the weather for more than 24 hours, but I came out the other side. It's a feature of several different vaccines, some much more than others. And I always treat it as a good sign. It means my immune system is waking up and taking notice.
Well, that's a very good point. So therefore, if you don't have any side effects, does that mean that you're not generating an immune response?
Thank you for pointing that out. The answer is clearly no.
Good.
So you do not have to suffer in order to develop a good immune response. You can develop a very good protective immune response even without any symptoms. Thank you for reminding me.
That's very reassuring for those who haven't been unwell following the vaccine. Judith, I don't know, I think I saw your hand up.
Yeah, I just want to emphasize, to reinforce what Charles has said, and to say that, if you're two things, if you are vaccinating the whole population and there is an underlying rate of blood clots, then by chance you will have an association of a vaccine occurring at the time that a blood clot does. And that's a very, very well established phenomenon, sort of bias confounder. And so you have to do proper studies that look at rates over time in properly controlled populations. And the MHRA are doing, and JCVI are doing those studies. And the second thing is, again, we are vaccinating a group of people or large numbers of people who would not normally be receiving vaccines. So anybody between the ages of around 18 and 60 or 65 would not normally be being vaccinated very much. And so, you know, we're immunizing people with vigorous immune systems, and they will have side effects. And these side effects are not trivial, but as Charles has said, you can sort of, you know, as you sit there shivering and feeling unwell, you can take some comfort in the fact that you're making an immune response, which is, you know, obviously what's desired. And the symptoms usually, you know, for the most part, pass very quickly.
Thank you very much. Right. So my next question is going to be from Professor Matheson, and then that will be followed by David Slater.
Hi, thank you very much. Yes, Peter Matheson here. I'm principal of the University of Edinburgh, and I happen to have a medical background, and inappropriately, lots of my colleagues think that makes me an expert, and I'm very keen to emphasize that I'm not an expert. Judith made the point about everyone's an expert these days. I wanted to just, I mean, that vaccine discussion was very helpful. My question follows on precisely. We're at a very interesting stage of the vaccine rollout in the UK, where we're now moving from high-risk people, where the vaccine clearly has a risk-benefit balance tipped towards benefit because they're at such risk of a disease, into lower risk populations where vaccine uptake rates are expected to be lower. And I just really wanted the panel's views on the sort of how the public are supposed to manage this constant barrage of information, most of it from non-experts, where we don't have the normal mechanisms of post-marketing surveillance or whatever that we'd have for any other kind of newly introduced drug. When people are making day-to-day decisions which are going to affect the rate of vaccine uptake. How on earth do we manage the public information on this topic?
Melinda, please.
Yeah, I think it's a very important point. So with the Royal Society and British Academy, we also worked on a vaccine deployment report, and we looked at vaccine hesitancy, what you're talking about now. If we see comparatively, actually the UK in the older populations, but they've also had that for seasonal influenza, actually a very high uptake comparatively. We have some countries such as France, you've probably seen it, that have historically struggled with very low trust and low rates of vaccination. And, you know, and so a lot of hesitancy. And I think you mentioned it in your question as well too, about it's largely to do with where people get their information. So we're trying to understand more where people get their information, and there's lots of misinformation or disinformation, incorrect information that's being spread around, particularly on places such as YouTube, where about 60% of the information about vaccines is incorrect, but it's also not spread by experts, it's spread by individuals. so that's some you know, important points. And I know that there's been a lot of focus on that. But I think also just working together with local leaders has been quite important as well, with looking at vaccine hesitancy and obstacles to being vaccinated in different, you know, using different religious leaders or community groups has been quite important as well too. I think I'll leave that. And complacency, that's the biggest problem for youth. That's going to be the biggest one. We see it all the time, that they just don't think that, you know, they are at risk to become ill. So that's going to be a big issue to tackle.
Thank you, Shaun.
There's one further point, which is actually beyond vaccines, and it's for whose benefit are you having the vaccine, which I do think is potentially something that therefore relates to all of the other things that we've been asked to do, for example, face coverings. So an individual getting a vaccine is not all about you. And that certainly has been rather more prevalent. Certainly early on in lockdown 1, the selflessness aspect was really to the fore. And I think perhaps the same kind of approach has some degree of bearing on how we sort of communicate regarding the vaccine as well.
Yes, and I think it's worth reminding people now that we've got some good figures on the reduction in transmission, which we probably didn't have at the start of the vaccine programme. There is a greater argument that you're doing it not for you, but for the greater good. Yeah. Charles.
A brief point to supplement Melinda's point about the community leaders. It's well established that people are more easily persuaded by their personal contacts than by someone, so-called experts, such as us, or people they see on the television. And So whether it's a community leader or a neighbor or a friend, if that person passes on some advice or information, they're much more likely to accept it. And that's, of course, one of the reasons that there's been this steady increase in uptake and acceptability of vaccines, both in this country and elsewhere. I read this morning that in Germany, the willingness to accept a vaccine against COVID has gone up from 64% to 75% in just 2 or 3 months. And that's as people see their friends and neighbors and so on getting vaccinated, and they say that they see that they survive and they're prepared to accept it. They don't have lasting ill effects. So, and in this country, I think it's still, we're among the highest in the world. The latest percentage I saw was that 94% of adults are prepared to accept a COVID vaccine, which is excellent.
Indeed it is. Thank you for that. Right, so my next question is David Slater, and then we'll go to William Duncan. David, if you unmute yourself.
Thank you. Yeah, thanks, Stephen. I have 2 brief questions. The first one for the panel. The first one is, does the government use its QALY system to determine which mitigation measures are justified? And my second one is there a relationship between viral load that people receive, perhaps expressed in micrograms, and the severity of the symptoms that they get? Thank you.
Thank you, David. Who would like to go first? I'll go with Judith first, and then I'll come to you, Charles.
I can't answer about the QALYs, although I imagine that at this point, there haven't been the studies done that would involve analysis of the QALYs, but I'm not an expert on that. But as far as the viral load, we know that for very, very many viral infections, viral load is critical, and that's, you know, especially respiratory viral infections. That we know that the load you're exposed to is absolutely critical. I don't think we have any really good data yet on the SARS-CoV-2 virus that viral load is associated with greater severity. There are a number of studies ongoing, and one particularly good one that could answer that is the household exposure studies. And we know that with other viral infections that being exposed to the virus in the household often leads to, or can lead to, more severe infection if you acquire it that route, because you're in close proximity and you're exposed to somebody at the time that they're most infectious. You know, the other thing, of course, and I'm sure Shaun can comment on this, is that we know that being in a closed environment is also a greater risk, but we don't know whether this is a risk for just a greater risk for infection, or whether actually that has a risk for severity. So I think the studies are still ongoing that will tell us that. There are some data which suggest that the viral load of the B117 variant is higher than for other variants, and that has been indirectly associated, or perhaps there's been questions as to whether that might be responsible for the greater severity of disease that has been described. But as I say, we have no absolute evidence for that at all, as far as I'm aware.
Thank you, Charles.
Yes, this is a very complicated question, and we had a very interesting debate recently, among others, with the director of the Wellcome Trust, Jeremy Farrar, who himself is an expert on viral diseases. My own view is that, as Judy says, we haven't got good data in the case of COVID. My own view is this, that the viral load is much more likely to affect the probability of acquiring the infection than the severity of the resulting disease. And the reason is very simple, that once you acquire, if the infection takes when you, if you're infected with it in the first place, it will replicate exponentially. It replicates extremely fast. So if you're given a small dose it may lag by half a day or a day, but the replication of the virus will very, very rapidly catch up with those who are inoculated with a larger dose. But that's different from the other point that Judy made, which is again exactly right, which is that the variants could grow to a higher load. That is associated with, appears to be associated with worse disease in some people, but that may be because it replicates more efficiently. If it replicates more efficiently, it may spread around the body more easily. It's harder for the immune response to counter, and therefore will cause worse disease in that person. But because it also replicates to a higher amount, higher load, it's more likely to be transmitted from that person to another person. So the variant may cause more severe disease and is more transmissible. But that's not to say that it's the amount that you actually receive that determines the severity. As I say, we haven't got the data yet. It needs to be tested properly.
Thank you. Right, our next question is from William Duncan. William, good evening.
Good evening, and thank you for a fascinating presentation, all of you. My question is about how we should look after and treat the people who develop long COVID, and both in relation to what the NHS might do, and particularly about how GPs might be advised in relation to who to refer to long COVID clinics and what type of support people might be able to receive when they attend these clinics. But I also have a question about what sort of advice employers should be given where they have staff who are experiencing long COVID. End of my questions. Thank you.
William. Perfect. I presume, Charles, that's...
Yes, and these are extraordinarily important questions which at the moment have no clear answer. As I mentioned earlier, the NIHR and UKRI are funding a lot of research on this, and part of a large part of that is on precisely this question: how best to manage it, and how to treat it both with drugs or with behavioral aspects or any other form of treatment. It's simply a number of different approaches are being tried. We don't yet know how long it's going to go on, so it's very difficult to give clear-cut advice to employers for the same reason. I think the most important thing is this: it needs to have, I emphasized its heterogeneity, its variable nature. That makes it very, very difficult to define. But NICE has done its best to define this. And the most important thing is that it becomes recognized by the medical profession, by everyone else in society, and of course by employers, so that the people who are diagnosed with it are not somehow dismissed. Their symptoms and their signs are not dismissed as being malingering or psychosomatic, and that therefore due provision is made. But how much provision is made and what form that takes, those are questions that really are not yet answered.
Thank you for that, Charles. Right, my next questioner will be Robert Jackson, and then we will go to Claire Ayres. Robert. If you could unmute, Robert. Are you with us? Okay, perhaps we'll come back to Robert. Maybe he's just stepped away from the screen. Perhaps Claire Ayres, if you'd like to ask your question on behalf of, I believe you're from Owen Patterson's office. No.
I'm not sure if Claire is on the call, Stephen.
Oh, right, okay. In that case, we'll go to Anthony Kearns.
Hello, yes, I have a question. Can you hear me?
We can, thank you very much.
Excellent, thank you very much for the excellent presentations. My question is, what services are being offered with respect to monitoring people's antibody titers after receiving vaccine doses? In other words, what's happening to the antibodies in people after a period of time after vaccination?
I'll mute this. Okay, who would like to have a Judith? Thank you.
I can answer that to some extent. I mean, there are studies ongoing to look at the levels and duration of antibody produced to the vaccines. And of course, there are studies in relation to the variants as well. And there are also studies looking at people who get infected who have been vaccinated and trying to determine whether if they become infected, that's perhaps in some way related to their antibody level. But it would be a huge process to monitor antibody levels after every vaccine. And we still really don't know what the correlate of protection is. We're getting nearer to understanding what it is, what feature of the antibody response actually is associated with protection against infection, but that's still work that's ongoing. So on the whole, the approach is to take the data from the clinical trials and from post-surveillance studies, which obviously seem to hold up to, are similar to what was found in the clinical trials, and then assume that in most cases, people will behave in the same way as has happened in the studies. But clearly there are certain groups in whom there are special studies going on, more in the elderly perhaps, and also more in immunocompromised patients. And then there are studies looking at particular antibody levels in relation to variant and reinfections.
Thank you very much. Excellent. Charles, yes.
Thank you. It's very important to realize that the antibody level does not give an absolutely clear indication of protection. As Judy has just said, we don't yet know the correlates of protection. In other words, what it would be ideal to measure in the immune response that really indicates whether that person is protected or not. And further than that, it's clear that after one dose of a vaccine, the antibody level slowly declines over about 3 months, but the degree of protection does not decline. Now, part of the reason for that, a large part of the reason for that, is likely to be that antibodies are not the only thing in the immune response that kills viruses. You've got the T cells, the lymphocytes, and they play an important and sometimes critical part in this. And in fact, you can have good protection against the disease, even without any detectable so-called neutralizing antibody. Normally, you can detect some. We had a talk at a seminar last week from Professor Pollard, Andrew Pollard, who's leading the Oxford AstraZeneca vaccine initiative. And he gave the latest data on this, and he showed that the protection against severe disease after one dose of the AstraZeneca vaccine does not decline over 3 months, although the antibody level slowly goes down. So it's very difficult to know how best to measure this. Finally, on the duration of immunity, again, as Professor Breuer mentioned earlier, the seasonal coronaviruses that have been around for many years, they tend to reinfect us every 2 or 3 years because our immune response to them doesn't last very well. But we don't yet know how long lasting any immune response to this one will be. And in fact, there's good evidence that the immune response to SARS, which is the closer relative of this one, can last for more than 10 years. So there's some hope that the immune response to this coronavirus might be longer lasting.
Thank you. Right.
Stephen, if I may, I have the question from Owen Patterson. Owen would have another question for Professor Bangham, and the question is, what is Professor Bangham's views on the mental health impact of COVID?
Long COVID.
Of long COVID.
Long COVID.
Of long COVID specifically?
Yes.
I think this is an extraordinarily important question. As I mentioned at the beginning, initially, particularly, some people presenting with what we would now call long COVID were having their symptoms dismissed, or their doctors were treating them with antidepressants because it was being ascribed to purely psychosomatic or causes. That this is yet another reason why it's really important to have a clear and well agreed definition, case definition and identification, so that it's well recognized. Really, if you're going to attach a label to a condition that any patient has, then he or she is likely to feel better. They feel justified. If they come along and say, I got these strange symptoms, and no one knows whether it's a real condition or not, that adds to the mental burden very considerably. Now, of course, that doesn't solve the problem because the condition itself imposes a huge strain on people. And naturally, if you have prolonged fatigue or chest pain or breathlessness or the brain fog, then, there's no one can tell you how long they're going to last or whether they will ever get better. That's bound to impose a very severe strain on your psyche. So it's really important to offer the support, to the psychological support, as well as trying these different physical treatments.
Thank you. Right. My next question will come from Peter Lilford, sorry, and then John Lowe.
Yes, can you hear me?
Yes, Peter.
Thank you very much. In fact, the last question was very relevant to mine, and that relates to the definition and the effects of long COVID. There's a very interesting Lancet report come out recently relating neurological complications to the possible, as a COVID-19 being a possible source. It seems to me that this sort of study is going to be vitally important to the NHS because it may mean that we have symptoms which could better be described as long lifetime COVID. And I wonder whether these such studies, very long studies, are going to be continued relating to both neurological health and other side effects of the virus effect on the body.
Thank you, Peter. Charles?
Well, absolutely, yes. It will be essential that these large studies that are now being started, among other places in the USA and here, to follow the course of the long-term effects of COVID, both the long-term effects of acute COVID, from which people get better, and the so-called long COVID syndrome. It's really important that these studies continue. And at the moment, they're completely open-ended for precisely the reason that we don't know how long it's going to last. But it is of absolutely vital importance, yes.
Can I just follow that up and say, in terms of guidance to the average GP, how does this information get transmitted to assist them in treating patients with these long-term symptoms?
Well, I think the most important first step is to get the information about the existence and the nature of the syndrome. At the moment, as I've unfortunately had to emphasize, we don't know enough about how exactly it's caused or what best to do about it. But the most important thing is that people recognize it. They give it a label, they offer the person the psychological support. If they wish to take part in the studies that are being carried out nationally to try different forms of treatment, it may be appropriate for them to take part in those. But at the moment, it's a matter of information and case definition, I think, more than anything else. That must precede any effective institution of treatment or clinical management.
Thank you. Right. If we are quick, we probably could get two more questions in. The first one will be from John Lowe, and then if we have time, the final one will be from Neil Gow, who is asking about what we have learned from children. So, John,
Yes, thank you, Stephen. To some extent, Melinda Mills covered this point earlier on, but I want to set it as a generic question and just use one country as an example. I have professional dealings between Japan and the UK, engineering matters, and we're concerned about travel between the two. So let me jump forward to, say, the 21st of June, when things are a little clearer. It is likely at that point then that because the Japanese vaccination program is way behind many others, that the contacts that we have over there aren't necessarily going to be vaccinated. Of course, Japan has a lower rate than we have, but that could change. So supposing I want to bring an engineer from there over to here, or for that matter, I want to go over there, and the two countries are out of sync with each other, how best would I have a program to bring that person here? Could they, for example, I'm not suggesting this, I'm just using it as an illustration, could they, if they can't get the vaccination in Japan, could they come over here and buy a test over this side, or can they buy a vaccination?
Thank you, John. Melinda, I don't know. Yes, thank you.
Yeah, I'll give you a quick answer. Yes, so this has already been asked by some companies as well. You might have heard of the cruise liner that wanted to ensure that everyone was vaccinated when they came on board. But then there was the question, well, most of the staff is foreign, so from the Philippines and different countries. So they thought about having people quarantine and test at the moment. So that's been some of the discussion that's been there. But there's definitely also been a discussion about, if vaccines are available, what will be the options? But then you get into an inequality question about, if it starts becoming, a pay-for service, some regulations and rules would have to be set up. But that question is being asked by a lot of people right now. So it's very relevant. Shaun.
I would just add that there's an issue of timescales as well. I mean, in terms of quarantine period versus actually after you've had the vaccination, how long it then takes for you to actually build up some degree of response. So I think it's a broader question regarding in terms of what kind of measures that might be put in place.
Thank you. I've just spotted that one of my colleagues from the Lords has also had his hand up. So I don't know if everyone flexible for a couple of minutes, if we go over past 7 just for a couple of minutes. In that case, I'll stick to my original plan and go with Neil Gout, and then I'm going to go to Malcolm Caithness. Neil.
Thank you very much. Fascinating session. My question is what we've learned from looking at young people and children who clearly have very mild symptoms or can be completely asymptomatic, but we know that they have significant viral loads, and then for presumably vaccination of children remains important if we want to reduce transmission and therefore variants arising. So I work at the university. We know that, for example, in halls of residence with dense populations, you have really very high levels of transmission of people who are sharing accommodation. So what we learn from children, and what does that mean for our vaccination strategy?
Thank you, Neil. Anyone like to comment? Judith, thank you.
So I think you're absolutely right, Neil, that the children do have, we know that children transmit the virus. Unfortunately, they don't seem to get as sick, although we do have the occasional case of PIMS-TS, which is a sort of allergic response to the virus. So they're not completely unscathed. So there is some disease in children, but I think that we already vaccinate children against influenza in order to prevent transmission, and this may be something that we need to consider. At the moment, the vaccines are actually not licensed for children under the age of 18 or in one case 16. And so there will need to be studies done to just verify that the vaccines are suitable for children. But I think eventually that is going to be something that we will all be asking about, because I think we are interested in reducing transmission, not only to protect children themselves, but also to protect those few people who may not be, in whom the immunization may not work very well.
Judith, thank you. Right, oh, Shaun, sorry.
Very briefly, in terms of expanding this to young people, and you mentioned from the university, yes, we have learnt actually quite a lot about the transmission routes as a result of, for example, halls of residence. So the idea of people living in very close proximity, lots of degrees of mixing, that actually has been quite positive in terms of building our own understanding about, therefore, about mitigation measures that are necessary.
Thanks for that, Shaun. Right, so we're now going to go to Lord Caithness, Malcolm, and then the very final question will come from Baron Campbell-Savers.
Thank you, Stephen. And that's all very interesting. A question for you, Shaun, please. You said that we might have to, you were looking at the design of buildings. What does this mean for commercial and residential buildings? Does it mean that the building regs will have to be altered? And given the house building programme, if that's going to happen, the sooner it happens, the better.
So, excellent question. I don't want to prejudge the outcome of a consideration as to, therefore, what might need to change with buildings. However, right now, my greatest concern are for buildings that don't actually meet the current codes. So when you've got buildings that are really inadequately ventilated, so ones that are not meeting your 5-10 litres per second per person kind of ventilation rates. So they're the ones that when we've looked at the case studies that have had these outbreaks and associated with those. So I don't want to prejudge the outcome, but it's actually even compliance with the current codes would be a massive step forward in some instances.
Thank you for that, Shaun. And as I said, the final question goes to Dale. Baron.
Well, my question has just been asked, actually. It was on the question of the ventilation of buildings and to what extent there may well be a need for a national programme to modify many hundreds of thousands of hospital rooms, public conveniences, offices and all sorts of other sealed rooms in buildings across the country.
Again, I don't want to prejudge the results, for example, of findings when we go and monitor buildings to find out whether they are adequately ventilated or not. Clearly, the buildings that are relatively new, they should have been built in accordance with modern building standards. And if the investigations thereafter find, and for some reason, that they weren't, then there would need to be some remedies. It's the older buildings in particular that might be therefore of greater concern. However, the older buildings themselves, and this doesn't help us on the energy efficiency tag, but many of them are actually quite leaky and therefore you've actually got natural infiltration that weirdly therefore might actually be a benefit to us in terms of ensuring you've got some degree of background ventilation. So
can I put it too that the modern buildings that are being built, modern office blocks, which are unventilated because their windows don't open, and hotels and many hospitals, they could be a major problem.
Well, my experience is that many modern buildings, they do tend to have mechanical ventilation systems associated with those. So even if the windows aren't openable, then they are designed to certainly meet the building regulations. If they're not, then actually there would need to be some rectifications of those. But many of the buildings that I have reviewed are indeed compliant, the more modern ones. But the ones that for some reason get through the cracks and haven't been reviewed properly and therefore get built and they don't have a ventilation system and the windows are either inadequate or don't open at all, yes, there will need to be measures put in place to ensure that those spaces that are going to be occupied are then suitably dealt with.
Thank you very much indeed, Shaun. Very sadly, time has beaten us, which is one of always the biggest challenge is getting those. We've got more questions than we have allotted time, but I am incredibly grateful to everyone for participating, for all my questioners, but of course particularly to my panel, Shaun Fitzgerald, Charles Bangham, Judith Breuer and Melinda Mills. Thank you very much indeed for your contributions this evening. I think it's been an absolutely fascinating and wide-ranging discussion, and I'm sure that we're all incredibly grateful for your time this evening. I'd like to thank particularly Becky Purvis from the Royal Society, and Joseph Lewin from the Academy of Medical Sciences for their help and support, and also Daniel Callahan. I think we also owe you a debt of thanks, so thank you for that. Of course, thank you, as I said, to the audience and to the questioners, and particularly to the Parliamentary and Scientific Committee team, to Lee Jeffs, to John Slater, Karen Smith, and particularly Ben Allen for doing the techie side today. Thanks, Ben. And to Alfie Hoare, who will be writing up a report of our meeting, which will get published in our quarterly magazine, Science in Parliament. Thank you to all of you. Our next Zoom discussion webinar will be on Monday, the 12th of April at 5:30, a big day all round, when we will be discussing the National Quantum Programme, which we are organising in conjunction with Innovate UK. So I hope that you will be able to join us for that, which again will be a fascinating discussion. But until then, stay safe, and I hope you've enjoyed this evening as much as I have. Thank you very much.